and Mohammed bin Rashid, University of Medicine and Health Sciences. She is an expert in dealing with pediatric asthma, interstitial lung disease, cardiopulmonary exercise testing, and a whole host of other pulmonary diseases. And she's going to talk about recent updates on pediatric asthma and guidelines.
Thank you so much. Hi, everyone. My name is Rizwana Popatia. Okay. So today I'm going to present updates in management of pediatric asthma. Now, we all heard about how chronic inflammatory problem asthma is. And if you just look at plain numbers from American Academy of Allergy and Immunology, 300 million people worldwide are affected with asthma. And it's increasing by 50% every decade. 1 in 10 people in this world has diagnosis of asthma. And in pediatric age group, it is the leading #1 cause of chronic morbidity and disability and missed school days. And currently 5 million children only in US under the age of 18 has asthma. So today my task is to present the updates on pediatric asthma management. Now we all come across this tens to hundreds of pages of guidelines. And it's whether it is GINA guidelines or whether it is NHS guidelines. Here I'm going to present the summary of the focused update to the asthma management guidelines. And this is based on a report published by the National Asthma Education and Prevention Program, where they formed an expert panel. And this working group, they help clinicians to integrate the new recommendations into clinical care. So there are hundreds of pages of guidelines for our reference, but what does it mean to me in my clinical practice? And that's what we're going to look at today. And there are 6 parts of this updates in the pediatric asthma management, and we'll go one by one. There are only 20 slides, so we'll try to finish it faster. One is intermittent inhaled corticosteroids, long-acting muscarinic antagonist or LAMAs, indoor allergen mitigation, immunotherapy, FeNO or fractional exhaled nitric oxide testing, and bronchial thermoplasty. So we're going to quickly look at each one of these and how does it help our clinical practice. We'll start with a case. Now this case is like 70% of children presenting to my clinic, and I'm sure with a lot of other pediatricians as well. So he's a 2-year-old boy presenting to the clinic for cough of 2 days duration with slight increased work of breathing, setting of runny nose. So 2 days of cough, started with runny nose, little bit increased work of breathing. On physical examination, he does not have fever, slightly increased respiratory rate of 30 per minute, and bilateral scattered wheezing. This kid also had a similar episode 4 months back in the setting of RSV infection. He's completely fine in between the episodes. What is the next best step in the management of ARI? Whether you will give him short-acting beta agonist or we call SABA as needed, we give him low-dose inhaled corticosteroids daily and SABA as a rescue. We put him on intermittent inhaled corticosteroid and SABA as needed, or you observe the child. Any comments from the audience? A, B, C, D. Any noise? D, observation? Sorry, it didn't go, but the correct answer is intermittent inhaled corticosteroid and SABA is needed. And you're right. See, that's how, we have a lot of clinical guidelines. But what does it mean to me in my clinical practice if this kid comes to my clinic? So intermittent inhaled corticosteroids, and this is for children under 4 years of age with recurrent wheezing, and it's a very common scenario in UAE. So in children between 0 to 4 years of age who has recurrent wheezing, a short course, which is 7 to 10-day course of daily inhaled corticosteroid with rescue SABA, short-acting beta-2 agonist, is recommended starting at the onset of a respiratory tract infection, not after 5 days, not after 2 weeks. So at the beginning of the respiratory tract infection, you start them on 7 days of inhaled corticosteroid and use SABA, PRN as needed. Now, what does it mean? Again, implementation guidelines. What do you do when the patient comes to your clinic? So the population is children under 4 years of age with recurrent wheezing. And how do you define recurrent wheezing? So recurrent wheezing is 3 episodes of wheezing in the lifetime or 2 episodes of wheezing in the past year in the context of viral upper respiratory tract infection. And this kid should not be taking any daily treatment. If this patient is on daily low-dose inhaled corticosteroid, you don't need to start this regimen. Treatment, you use budesonide inhalation, 1 milligram twice daily for 7 days. And why am I putting this information? Because this dose for intermittent inhaled corticosteroid is higher compared to your low-dose daily inhaled corticosteroids. It causes reduction in exacerbation requiring systemic steroids. And the risk factor is it could affect growth. So growth monitoring is important while patient is on this regimen. And caregivers can initiate intermittent inhaled corticosteroid treatment at home, so they don't need to visit the clinic or the hospital to start the regimen at home by themselves. So this is under 4 years of age. Now this is another common scenario. So Mariam is a 5-year-old girl with moderate persistent asthma. She has allergic rhinitis and she's coming to your clinic for a follow-up visit after recent hospitalization for an asthma exacerbation. She has moderate persistent asthma, so she's already on low-dose inhaled corticosteroids daily with good compliance. She takes Ventoline as needed, she takes Zyrtec as needed. Her physical examination is unremarkable in the clinic. What is the next best step in the management? Would you increase the dose from low-dose inhaled corticosteroid to medium dose? You will start inhaled corticosteroid and formoterol as a single inhaler. You will add montelukast to the regimen, or you will add cromolyn sodium to the regimen. Any voices from the audience? Anything? Any guesses? Maybe C? Okay. So A? Okay. So the correct answer is B. And again, that's the update in the management of asthma. Okay, so this is individuals 4 years and older with persistent asthma. So kids who have mild to moderate persistent asthma, who are taking inhaled corticosteroid treatment daily, and they are adherent with their prescribed medication, increasing the regular daily inhaled corticosteroid dose for a short period is not recommended when symptoms increase or peak flow decreases. This girl recently had an exacerbation, so you usually don't increase the dose of inhaled corticosteroids from low to medium dose. In such cases, the expert panel recommends against it. Now, in kids with moderate to severe persistent asthma who are already taking low or medium dose inhaled corticosteroid, the preferred treatment is a single inhaler with ICS and formoterol, and this is referred to as SMART therapy, single maintenance and reliever therapy, which is used daily and on needed basis. So, and what happens with individuals 12 years and older with persistent asthma? You have two options in those kids who have mild persistent asthma. Either you put them on daily low dose of inhaled corticosteroid and SABA is needed, which we do most of the times, or the other option is you can put them on intermittent inhaled corticosteroid and SABA as needed. And this intermittent therapy is given as you give 2 to 4 puffs of albuterol, followed by 80 to 250 micrograms of beclomethasone every 4 hours as needed for asthma symptoms. So it's a PRN therapy. And again, it can be initiated at home. Not good for individuals who does not have good perception of their symptoms. And daily low-dose inhaled corticosteroid with SABA as needed. So number 1 option is preferred over number 2. For 12 years and older with moderate to severe persistent asthma who is already taking low or medium dose inhaled corticosteroid, again, the preferred treatment is SMART. So please remember that ICS, formoterol, single inhaler, daily and is needed. And what does it mean in terms of my clinical practice? I can give it to individuals 4 years and older with a severe exacerbation in the prior year. Who should not receive the treatment? You don't start this ICS formoterol combo in individuals who already on ICS salmeterol as maintenance therapy. Now, SMART only refers to ICS formoterol combo. Treatment, you give inhaled ICS formoterol as a single inhaler. This form of therapy has been studied with only as formoterol as the long-acting beta-2 agonist. It is appropriate for step 3 if a patient is on low-dose inhaled corticosteroid, or step 4, patient is on medium-dose inhaled corticosteroid treatment. Individuals whose asthma is not controlled on maintenance ICS-LABA with short-acting beta agonist as a PRN therapy should preferably receive SMART therapy before moving to higher step of therapy. So this is most important and the newest update in the asthma management guidelines for pediatrics. ICS formoterol should be administered as a maintenance therapy with 1 to 2 puffs once or twice daily, depending on the age, depending on the severity of symptoms, and depending on the ICS dose in your preparation. And then you can use 1 to 2 puffs as needed for asthma symptoms. So this is for kids who are 5 years, 4 years and older, who is on mild to moderate persistent asthma, who had sickness in the previous year or frequent exacerbations. This therapy, single inhaler, can be used both for rescue and maintenance. Maximum number of puffs per day is 8 for children under 12 years, and you can give maximum 12 puffs for children over 12 years. Advise individuals to contact their physician if they need more than that treatment. And the dose of formoterol was based on 4.5 microgram per inhalation, which is the most common preparation used in the studies which were reviewed. The benefits of SMART therapy: they reduce asthma exacerbations requiring unscheduled medical visit, they reduce the requirement for systemic corticosteroids, and they improve asthma control and quality of life in children. Reduced exposure to oral corticosteroid as a potential benefit, it suggests that the intervention might reduce future corticosteroid-related side effects as well. The risk: there has been no difference in the documented harms between SMART therapy or daily ICS or ICS-LABA when you use short-acting beta agonist as a rescue therapy. So there is no additional harm in this treatment. Other considerations: so in children ages 4 to 11 years, and it's very important for parents to know that there may be a lower risk of growth suppressions among those children taking SMART therapy versus the one they are taking daily high-dose ICS, inhaled corticosteroid. So SMART is slightly safer than daily high-dose ICS treatment. However, it is limited by cost, formulary considerations, availability in different countries, and medication intolerance. One other thing we need to remember as physicians is 1 month supply of ICS formoterol medication could be insufficient because you're using it as a rescue medication and as a controller medication. Now, part 2, which is our long-acting muscarinic antagonist, or LAMAs. So it's used in individuals 12 and older with uncontrolled persistent asthma. You use it in individuals with asthma, which is not controlled by ICS therapy alone. Adding a LABA is better or recommended compared to LAMA. So LABA should always be your first choice, then LAMA. However, if by any reason you cannot use LAMA, if the patient is not tolerating it, they can't use the device, or it's not available, then LAMA is an acceptable alternative, but it should not be the first choice. For individuals whose asthma is not controlled with ICS-LABA, adding a LAMA could be beneficial as it can have small potential benefit. Again, what does it mean to you in your clinical practice? When do you use this treatment? In ambulatory settings, never in acute settings. Who should not receive this treatment? Patients who are at risk of urinary retention or glaucoma should not receive the treatment. Potential benefits: again, it improves asthma control and quality of life, and it can have a small potential benefit. Risk: there is no more benefits or increased harm compared to addition of LABA, and it requires a special device. So you need to give a special inhaler and teach the child to use that and keep on board with the technique of using that inhaler. Now we'll do case 3. Jack is a 7-year-old boy with mild to moderate persistent asthma and allergic rhinitis. He's currently on a single ICS formoterol inhaler daily. So you started SMART therapy for him, and he has reasonable control of symptoms. His allergy test result shows allergic to dust. Which of the following statement is true about allergy mitigation? Improve asthma outcomes. For individuals with an allergy to a specific substance, strategy to mitigate that improves asthma outcomes. Environmental interventions are not recommended in patients with asthma if they have no identified allergen. Allergen mitigation is simple and inexpensive. C, that's the correct statement. Anybody else with a different opinion? Sorry? 2B? Okay. The correct answer is C. So they're not, we'll see why each one of them is wrong. So studies which are reviewed have provided little evidence that allergen mitigation strategies are beneficial for improving asthma outcomes. For individuals with asthma who has an allergy to a specific indoor substance like dust, using multiple strategies is recommended. Using one strategy does not improve asthma outcomes. Again, that's an update. Integrated pest management in the home is recommended for individuals with asthma who are allergic to cockroaches or rodents. And for individuals with asthma who do not have identified allergies to indoor substances, you do not recommend environmental interventions. It doesn't help. Immunotherapy. Now, immunotherapy is the administration of an aeroallergen. Either you give it subcutaneously, which is we call SCIT or subcutaneous immunotherapy, or you give it sublingually via tablet or aqueous drops, and we call it SLIT. Now, in individuals 5 years and older with mild to moderate allergic asthma, the expert panel recommends the use of subcutaneous immunotherapy, which is SCIT, is an adjunct treatment to the standard pharmacotherapy. So you don't use it as a sole treatment, but you can use it as an adjunct therapy. Do not initiate, increase, or administer maintenance kit doses while individuals have asthma symptoms or they are severely asthmatic. So it's used only for mild to moderate asthma as an adjunct therapy, not as a sole therapy. You don't treat it during acute asthma attacks, and you don't give it to individuals with severe asthma. Similarly, with SLIT, the evidence does not support the use of SLIT for the treatment of allergic asthma. So sublingual is not recommended by the expert panel for the management of allergic asthma. Only SCIT, subcutaneous, is recommended. That too, it's a conditional recommendation as an adjunct therapy. Now coming to FeNO or fractional exhaled nitric oxide. So this is the, I think, the second last point, the fifth one. Now, you know, nitric oxide, we measure from the exhaled breath, and it serves as a measure of the level of airway inflammation in individuals with asthma. And it's a useful indicator for Th2 type of inflammation. And these values are very important to kind of get an idea of T2 inflammation in your airways. Allergic rhinitis and atopy can be present in individuals with or without asthma, and they can also cause increased FeNO levels. So taking these factors into consideration is very critical for accurately interpreting the FeNO test results. So what does the new asthma guidelines tells you about FeNO in your clinical practice? So in children 4 years and younger who have recurrent episodes of wheezing, FeNO measurement does not reliably predict the future development of asthma. So there is no point of offering FeNO or exhaled nitric oxide to kids under 4 years of age. FeNO measurement may support a diagnosis of asthma in individuals where the diagnosis is uncertain. So you've exhausted all the avenues, you've taken a history, you've done a good physical examination, you've done a spirometry with and without bronchodilators, and still the results are ambiguous. At that time, FeNO can be an adjunct marker or a investigative tool that can be used. Now, what in children 5 years and older, again, FeNO testing should not be used in isolation to assess asthma control, predict a future asthma exacerbation, or assess the severity of exacerbation. So individually, it's not useful at all. You can use it as an adjunct tool in circumstances when you're not sure. And bronchial thermoplasty, it's a procedure that uses heat to remove muscle tissue from the airways of adults with moderate persistent asthma. Most individuals aged 18 years and older with uncontrolled, moderate to severe persistent asthma should not undergo BT to treat asthma. Again, the panel recommends against bronchial thermoplasty because of unknown and severe adverse consequences. And some individuals with moderate to severe persistent asthma who have troublesome symptoms and they're willing to take the risk, they want to still go ahead and try this treatment, you should choose this intervention after shared decision-making with their healthcare provider. And BT has not been studied in individuals younger than 18 years of age, so we don't even consider bronchial thermoplasty for anybody under 18 years of age. And so these are the 6 main topics where we had these updates in asthma. And the previous panelists, these are 3 very quick slides I would go through. So under 4 years of age, I'm not going to go in the details. We all know this and we can all get the reference ourselves. Stepwise approach for the management of asthma. You start with the PRN SABA, then you can go to daily low-dose inhaled corticosteroid, then you can start your SMART therapy over here, and you escalate the dose. We all know about this. The only thing I want to emphasize here is you have to check asthma control at every point. And you check adherence, you check the inhaler technique, you check for environmental triggers, and you check for other comorbidities at every stage. You step up if needed. Once you step up, you reassess in 4 to 6 weeks. Once you step down, you can step down only if asthma is well controlled for 3 months, at least 3 months. When you can consider a pulmonary consultation in step 2, but in step 3 and step 4, you should invariably refer the kid to an allergist or a pulmonologist or an asthma expert. There is not much information on cromolyn and montelukast in this consensus statement or guidelines. And I just want to say that FDA had issued a box warning for montelukast in March 2020. This is, again, it stands same for year 5 to 11 years. The only thing I would add here is omalizumab is the only asthma biological agent which is FDA approved for this age group. So for children 5 to 11 years of age, only biological agent that's available is omalizumab. And again, it's the same thing. You assess the control using objective measures, self-repeated control, healthcare utilization on an ongoing basis. Again, I haven't touched more on theophylline or cromolyn sodium and all these things because it has untoward side effects and it's not easily available everywhere. Same holds for ages 12 plus years. This slide has been chosen by my 8-year-old, so you can see minions here, yeah. Thank you very much, and I'm happy to take questions. And I'm 2 minutes